Jose, from cardiac ultrasound, we'll move on to the next clinical challenge which all intensivists face, the ARDS challenge. So how does, in a regular bedside practice, ultrasound as a tool helps you in managing an ARDS patient?
Very relevant question, Jaicob. Ultrasonography is in fact a very useful bedside tool among patients with ARDS. It gives you lots of bits and pieces of information which would help you not only to diagnose the problem, but also to guide treatment as well. The way I look at it is, we all know that ARDS is not a uniform disease. It involves both the lungs, of course, but the involvement is not uniform. It is highly non-uniform, particularly with areas of sparing towards the apices, and the bases of the lung are much more involved compared to the apices. The extent of involvement can be readily picked up by bedside ultrasonography. It depends entirely on, one, the number of B lines, the number of B lines per ultrasonographic image, one. Second is whether the B lines are confluent or discretely seen. Confluence means bad, discrete is slightly better. And also, it gives you a good view of the pleura, the degree of pleural thickening and subpleural consolidation, which sometimes even the CT scan may not be able to tell you so much. So it gives you a very good idea about the degree of involvement and also the extent of spread throughout the lung. You can pass your probe from the apex downwards to the bases and look at the areas that are most involved. And there are several scores that have been proposed as well. The aeration score is one of those. The aeration score is based on subpleural consolidation and the number and type of B lines, as in discrete, coalescent, and the degree of subpleural consolidation, and other features of consolidation such as dynamic air bronchograms, tissue lung, and so on. So based on these parameters, aeration scores have been suggested, and I would strongly recommend that you do an aeration score based on this scoring system. It will allow you to follow up your patient with ARDS and actually see if they are getting better over time or getting worse over time. If you do it, say, a couple of times every day, it'll give you a good idea about whether, how much they are progressing in terms of improvement or deterioration. The second most important reason as to why I would use ultrasound in my practice is to look at recruitability. This is a very important question. We use PEEP fairly randomly without really looking at if it is actually going to help the patient or not. Recruitment to be effective, the application of PEEP to be effective needs recruitable lungs. If the lungs are not recruitable, regardless of the level of PEEP you apply, it will not reflect as obvious clinical changes. Like, for instance, the ARDS-NET group, they suggest application of PEEP based on the FiO2, but that's very empirical. It doesn't take into account recruitability at all. Recruitment maneuvers as such by application of a constant inflation pressure may actually be harmful, as some other studies like the ART trial has shown us. But ultrasonography, you can see with your own eyes, you can directly visualize. If you place the probe particularly in the most involved areas at the lung bases and slowly apply incremental levels of PEEP over a matter of a few minutes, just a matter of few minutes by the bedside, you look at the lungs and see if they're actually opening up. The obvious change will be from, say, dynamic air bronchograms to coalescent B lines. That is progress. It means it is getting recruited. Or it might actually improve from coalescent B lines to discrete B lines. That again indicates recruitability. So based on these findings, you can tell if the lungs are indeed recruitable and whether the application of PEEP will actually improve recruitment, open up more alveoli, and improve the oxygenation and the compliance in your patient. In fact, several preliminary studies have been done in this regard. We are also in the process of doing a trial in this. And so far, from what we have observed, is that it's an extremely useful tool. You know, within a matter of minutes, if the lungs are recruitable and if a higher level of PEEP is going to help or not. So application of PEEP and titration of PEEP based on ultrasound guided recruitability is an important utility of bedside ultrasonography in the patient with ARDS. Third is many of these patients, as I mentioned, in the initial phase, they may be septic. You may give a lot of fluid, and that might actually contribute to the hypoxia, contribute to fluid-filled lungs, contribute to worsening of the ARDS. And that it may call for the de-resuscitation strategy. As we mentioned, Varghese score is one of those things that you can use. And the other thing that you can obviously use, if you're using diuresis, you start an infusion of furosemide, say 10 or 20 milligrams per hour. Look at the lungs, look at the aeration score at baseline and as you go every few hours. And they can actually tell, based on what you see direct visualization, whether the lungs are actually improving with your diuretic therapy or not. Of course, it will reflect as improved oxygenation as well. You may be able to come down on the ventilation. But here again, ultrasonography is an important tool. So to briefly summarize, it helps you to diagnose ARDS, look at the degree of damage done, extent of involvement of lungs, look at whether there is recruitable lung, and look at the response to treatment in terms of your ventilation parameters, ventilator setting, as well as if you're using a de-resuscitative strategy like with the use of diuretics.
I think a comprehensive coverage about use of ultrasonography in ARDS with regards to helping us in selecting the PEEP recruitment is an option for this particular patient, and also covering how do you proceed with the complications of ARDS and de-resuscitation strategies. Thank you for a good cover.
Thank you, Jaicob.